Welcome to the Rad on Smart Review GU Cancer Series. Today we are taking a massive stack of source material. We've got the latest ASTRO and AUA clinical guidelines, the updated consensus contouring atlases, and decades of pivotal phase 3 trial data. And we're synthesizing it into a hands-on planning workshop because, usually when we talk about a medical diagnosis, there is this underlying expectation of mechanical precision.
Oh, right, yeah.
Like, you break your arm, the emergency room takes an x-ray, the film shows that stark, jagged white line, and the doctor just points and says, there's the problem, right there.
Right, and I mean, it is comforting when pathology is binary. The bone is broken, or it is not. The structural failure is completely visible to the naked eye. We as clinicians, and certainly our patients, desperately want medicine to be that visible and, that categorized.
Exactly. But the moment you step into the world of genitourinary radiation oncology and specifically prostate cancer planning, that comforting X-ray paradigm just shatters. We are looking at a diagnostic and anatomical landscape that is quite honestly murky.
Very murky, yeah.
We are almost never just pointing at a definitive spot on a scan and saying, we only treat right here. Instead, we are dealing with a microscopic disease process that's operating within a pelvis packed with critical, constantly shifting structures.
It is the absolute definition of diagnostic muddy waters. And, well, the planning process reflects that uncertainty. For the previous sessions in this series, we focused heavily on the broader strategy, right? The what to treat. We covered how to categorize risk groups, the optimal duration of androgen deprivation therapy, or ADT, who makes a statistically good candidate for a brachytherapy boost, things like that.
Right, the biochemical triggers that mandate salvage therapy.
Exactly. But today, we're flipping the camera around, we're stepping out of the consultation room and sitting down at the computer. This is about the how. How do you actually translate that strategy into a safe, deliverable physical plan at the contouring station?
And that translation is exactly why this is such a high-yield topic for you, the resident, who might be listening right now while driving or commuting. Because when you sit for your oral boards, the examiner does not care if you can recite a generic phrase like, I would offer definitive radiation.
No, not at all.
That response is essentially assumed. It will not pass you. They are actively waiting for you to walk them through the simulation setup, the specific target contouring rules, the exact dose, the normal tissue constraints, the daily image guidance, and crucially, they want you to proactively identify realistic pitfalls before they even ask.
You really have to speak in a fluent, clinic-ready language that proves you are a safe attending. And stepping beyond the artificial environment of the oral boards, I mean, in your actual daily clinical practice, the difference between an excellent prostate plan and a frankly dangerous one is almost never just the prescription dose you type into the treatment planning system.
Right.
The prescription is, well, the easiest part of our job. The true artistry and the true safety lies entirely in the millimeter by millimeter trade-offs we make around the organs at risk. We are talking about the anterior rectal wall sitting flush against the posterior prostate, the bladder neck diving directly into the superior aspect of your target.
The penile bulb hanging just off the apex.
Exactly. A truly great plan respects those hard anatomical boundaries while still delivering a tumor ablative dose that cures the patient.
So to make this incredibly concrete, we are going to anchor today's workshop in a specific framework of 3 highly representative patient cases. Case A is our intact, unfavorable, intermediate risk patient. Case B is our post-operative salvage patient dealing with a rising PSA after surgery. And case C is our high-risk intact patient where the microscopic risk is so high that the entire pelvic nodal basin is firmly on the table.
Each of these 3 clinical scenarios teaches a fundamentally distinct part of the planning process. By the time we finish this discussion, you will have the mental framework to walk a junior resident or a very intimidating board examiner through all 3 scenarios flawlessly.
So before we dive into the complexities of case A, let's establish the baseline. We have to talk about the physical simulation principles that apply to virtually every single prostate patient who walks into your department.
Right, regardless of whether their prostate is still intact, whether it has been surgically removed, or if we're treating the regional nodes. Because if your simulation setup is inherently flawed, your beautifully drawn, meticulous contours will not save the plan. A bad sim guarantees a bad treatment.
So let's walk through that sim room experience. What happens to every prostate patient when they arrive for their planning scan? I guess we should start with positioning and physical preparation.
Yeah, the standard is supine. We typically place the patient in a foam leg cradle, pulling the legs into a specific reproducible geometry. It is an incredibly boring, mundane part of the setup, but, Boring is the ultimate goal here.
Right, boring is good.
Boring is the highest compliment you can give a radiation oncology setup. You want a lower extremity immobilization system that limits rotational errors in the pelvis and is completely reproducible day in and day out for weeks. But the external setup is just the shell. The real terrifying challenge in the sim room involves the internal anatomy.
You're talking about the bladder and the rectum?
Specifically, yes, the dynamic volumes of the bladder and the rectum. The core philosophy that I try to instill in every training I work with is this: prioritize daily reproducibility over idealized perfection.
That is a crucial distinction, because if you are a resident observing in the sim room, you might see a patient who drank an enormous amount of water, and their bladder is massively distended. And initially you might think, oh, this is fantastic. The bladder is so large, it is physically pushing all the small bowel completely out of the pelvis and away from our target.
Right. But the psychology of the patient on simulation day is a massive factor that we often ignore in textbooks. They are anxious. They have been given a sheet of instructions telling them they must have a full bladder. They are intensely focused on being a good patient, so they might drink an entire liter of water in the waiting room and hold it until they are sweating and in visible physical pain.
Just really suffering on the table.
Yeah. You put them on the table, you acquire the CT scan, the bladder looks enormous, the bowel is completely displaced superiorly, and the dosimetry team generates a dosimetric plan that looks absolutely gorgeous on paper. The constraints are easily met. But then, fast forward to week 3 of actual daily treatment.
Right, the reality sets in. By week 3, the patient is fatigued. They have baseline urinary frequency and urgency from the radiation irritating the bladder trigone. The urethral swelling makes it difficult to completely void, or conversely, makes it impossible to hold large volumes. They simply cannot physically hold that massive amount of urine anymore without extreme distress.
And suddenly, you pull up their daily cone beam CT on the machine console, and you see a bladder that is maybe 1/3 the size of what you scanned at simulation. Because that balloon has deflated, all of that small bowel that was safely pushed up into the abdomen has now dropped straight down, directly into your high-dose radiation fields.
Wow.
Your beautiful plan is now actively irradiating a significant volume of small bowel to 60 gray, which is going to cause severe, potentially irreversible toxicity.
Because the physics of the pelvis are unforgiving. A comfortably full bladder, perhaps requiring them to drink just 16 ounces of water 30 minutes before their appointment, that they can realistically hold every single day for weeks, is vastly superior to a painful, idealized bladder they can never replicate.
Consistent anatomy prevents toxicity. As for the rectum, the physiological goal is empty and reproducible. A full rectum at sim pushes the prostate anteriorly. If the rectum is empty during treatment, the prostate falls backward, out of your high-dose target volume.
And whatever your specific departmental workflow allows, whether that relies on daily microenemas, dietary modifications, or natural bowel regimens, an empty rectum reduces internal prostate motion and significantly spares the rectal wall from high doses.
Absolutely. Assuming the patient is properly prepped and immobilized, we acquire the imaging. For the simulation scan itself, a thin slice CT scan, typically with 2 to 3 millimeter slice thickness, is the mandatory baseline. We need the CT because it provides the electron density mapping required by the treatment planning algorithms.
But a question that frequently comes up is the necessity of MRI fusion. Do we really need to fuse a diagnostic MRI to our planning CT for every single prostate patient?
For intact prostates, utilizing MRI fusion is strongly preferred. In fact, many would argue it has become the definitive standard of care at modern, well-resourced centers. While the CT scan is mathematically required for the physical dose calculation, it is notoriously terrible at providing soft tissue contrast deep in the male pelvis. Everything looks like a homogeneous gray blur.
It really does.
If you force yourself to rely on the CT scan alone without MRI assistance, you will almost certainly misidentify the prostatic apex.
And the apex is the most dangerous area to contour blindly. On a standard CT, the inferior tip of the prostate seems to visually bleed straight down into the urogenital diaphragm and the external urinary sphincter. There is no clear line of demarcation. If you cannot see the border, human nature dictates that you will over-contour just to be safe. You will drag your target volume too far inferiorly, directly into the penile bulb and the sphincter.
And over-contouring there guarantees unnecessary permanent toxicity. You are going to increase the risk of strictures, incontinence, and erectile dysfunction. The MRI, specifically because it relies on proton spin relaxation times rather than electron density, gives you that beautiful, crisp demarcation of the prostatic capsule.
It's also essential for accurately defining the posterior base of the gland where it abuts the rectum, and for pinpointing any dominant intraprostatic lesions if you are planning a focal, simultaneous, integrated boost.
Exactly. That soft tissue clarity is vital. Now, to bridge the gap between our static planning images and the actual daily treatment delivery, we have to talk about internal localization markers. This is another area where clinical context completely changes your approach. We have to clearly differentiate between fiducial markers and soft tissue localization.
Okay, let's unpack this, because confusing intact marker protocols with post-op marker protocols is an incredibly common unforced error on the boards.
It happens all the time.
For intact prostate cases, placing fiducial markers is incredibly standard. These are usually tiny gold seeds placed into the prostate either transrectally or transperineally a week or two before the simulation scan. Having 3 or more markers, reasonably spread out throughout the gland, makes daily IMRT localization incredibly clean, highly accurate, and very fast for the radiation therapists operating the machine.
The gold seeds are highly radio-opaque. They show up as bright white artifacts on the daily kilovoltage X-rays or cone beam CTS. The therapists simply align the seeds on the daily image to the seeds on the reference plan, verify the surrounding soft tissue, and deliver the beam. But we must clearly delineate what happens in the postoperative salvage setting, because this is classic trap laid by examiners. You cannot just reflexively state, I will place gold fiducials into the prostate bed as a universal standard.
Right. If you are sitting across from a board examiner and you tell them you are going to blindly implant markers into every single post-op patient's surgical bed, they are going to stop you and ask you exactly what tissue you are implanting them into.
Because in the post-op setting, the prostate itself is gone. You are dealing with an empty space that has been sutured together. Placing needles into the vesicurethral anastomosis to drop seeds is unnecessarily invasive and potentially dangerous. Therefore, daily localization for post-op patients frequently relies much more heavily on soft tissue matching using the daily cone beam CT.
You align to the bladder wall, the anterior rectum, and the surgical clips left behind by the urologist.
Exactly. Now, to be comprehensive, some specialized academic centers do routinely implant markers or electromagnetic transponders into the post-op bed, but that practice is highly center-dependent. Do not present implanted post-op markers as a mandatory universal requirement. It shows a lack of situational awareness regarding different practice environments.
That is a critical distinction that saves you from looking inexperienced. So to summarize our baseline, we require a reproducible, comfortably full bladder, an empty rectum, a thin slice CT for electron density, an MRI fusion for target delineation in intact cases, and a clear understanding of whether our daily localization strategy relies on implanted gold seeds or native soft tissue anatomy. With that physical baseline established, let's dive into the clinical specifics with Case A, the workhorse.
This is the patient profile you will see in clinic every single week.
Okay, here's the presentation for Case A. We have a 64-year-old man. He is medically healthy. He has an International Prostate Symptom Score, or IPSS, of 7. For those tracking the functional status, an IPSS of 7 means his baseline urinary function is quite good. He also has strong baseline erectile function. He underwent a targeted MRI fusion biopsy, which revealed Gleason 4 plus 3 equals 7, also known as grade group 3 disease. This was found in 3 of his 12 biopsy cores. The pathology report notes a 9mm dominant lesion located in the right peripheral zone, which correlates perfectly with a PIRS5 lesion on his pre-biopsy MPMRI. His PSA is 9.4. On your physical exam, you feel a firm nodule at the right base, but no clear clinical extension beyond the capsule. The staging MRI confirms no definite extracapsular extension and, crucially, no seminal vesicle involvement. Furthermore, a staging PSMA PET scan is completely negative.
Okay, so based on those parameters, the Gleason 4 plus 3 score specifically, we are dealing with a classic, completely clear-cut, unfavorable intermediate risk patient. The primary Gleason pattern of 4 immediately elevates him out of the favorable intermediate category.
Precisely. After discussing options, the patient strongly desires definitive radiation. So placing you in the role of the resident on the hot seat, the consult question is comprehensive. How do you physically simulate, contour, prescribe dose, and evaluate constraints for the specific risk group?
The underlying philosophy here relies on matching the microscopic biological risk to your physical target volume. In the sim room, when you are staring at a grayscale image, it is very easy to blur those lines. Let's tackle target definition first. For this patient, our primary clinical target volume, which we will call CTV1, must include the entire prostate gland plus the proximal seminal vesicles.
Well, I'm going to challenge that directly because this is where the logic can feel contradictory to a patient or a junior trainee.
Okay.
Since there's no SV involvement on the MRI and the PSMA PET scan shows absolutely zero uptake there, can we just treat the prostate and ignore the seminal vesicles? Why intentionally expose the adjacent bowel and bladder to extra radiation dose for a theoretical risk?
That skepticism is exactly what drives good oncologic planning. To answer it, we have to look past the imaging resolution and understand the biology of microscopic spread. Prostate cancer doesn't just jump randomly. It tracks along defined anatomical pathways, specifically the ejaculatory ducts and neural pathways leading directly into the base of the seminal vesicles. Even our best PSMA PET scans have a spatial resolution limit. They generally cannot detect clusters of cancer cells smaller than 3 to 4 millimeters. So to determine who needs their seminal vesicles treated based on microscopic risk, we use a conceptual framework I call the SV stepladder. It is a fantastic mental model to organize your clinical reasoning.
Break down the rungs of that SV ladder for us.
At the absolute bottom of the ladder, you have low-risk disease. For low-risk patients, the standard of care is targeting the prostate gland only. The microscopic risk of cancer cells having migrated into the seminal vesicles is statistically negligible.
You do not chase them.
Exactly. Moving up one rung to favorable intermediate risk disease, for example, a patient with a PSA under 10 and a Gleason 3+4, the target is still overwhelmingly the prostate only, though some specific institutional protocols might include just the very base where the vesicles attach. But then we step up to the next rung, unfavorable intermediate risk disease. That is exactly what case A represents. For unfavorable intermediate risk, the oncologically sound, board-clean default is to contour the prostate plus the proximal 1 centimeter of the bilateral seminal vesicles.
The proximal 1 centimeter only, not the entire length of the organs.
Correct. The pathology data shows that when intermediate risk disease begins to invade the seminal vesicles, it almost always starts right at the proximal junction near the base of the prostate. It rarely skips to the distal tips. Therefore, treating the proximal 1 centimeter covers the vast majority of the microscopic risk while sparing the bowel that sits just above the distal tips.
And if we move to the top of the ladder,
Right, to high-risk disease, or clinical T3B disease, where there is visible invasion on imaging, then you must treat the full extent in the seminal vesicles. Utilizing this stepladder logic proves to an examiner that you are deliberately tailoring your target volume to the calculated microscopic risk of spread.
that biological rationale makes the contouring decision objective. So we have drawn our prostate plus the proximal 1 centimeter of the seminal vesicles. That volume is our CTV, our clinical target. But we cannot just treat the exact outline of the organ. The patient is alive, they breathe, causing pelvic floor movement. The rectum fills with gas, the bladder fills with urine.
Exactly. To account for that internal anatomical motion and slight daily setup variations, we must expand our CTV to create a planning target volume, or PTV. For the PTV margin in the prostate, you need to quote an anisotropic margin, meaning the expansion is not a uniform perfect circle in every direction.
Right.
A mathematically safe, standard answer is a 5 to 8 millimeter radial margin in the superior, inferior, lateral, and anterior directions. However, that margin must be tightly reduced posteriorly, where the prostate directly abuts the anterior rectal wall.
Because if you expand 8 millimeters directly backward, you are putting a massive volume of healthy rectal tissue right into your maximum dose region.
Exactly. With modern daily image-guided radiation therapy, meaning we are taking a cone beam CT or imaging our gold fiducial markers every single day before we turn the beam on, you can safely bring that posterior PTV margin down to 4 or 5 millimeters. For general practice and board exam purposes, quoting a 5 to 8 millimeter overall margin with a strict 4 to 5 millimeter posterior reduction is the classic, highly defensible standard.
So we have the target drawn and expanded. Now we face the prescription. What is your definitive go-to?
For an unfavorable intermediate risk patient like case A, my default strategy is moderate hypofractionation. Specifically, I prescribe 60 gray delivered over 20 daily fractions, which comes out to 3 gray per fraction. And crucially, because his biology puts him in the unfavorable intermediate risk category, I am pairing that radiation with a short course, typically 4 to 6 months, of ADT. That combination is bulletproof.
I am going to push back on that because the landscape of radiation oncology is shifting rapidly towards extreme efficiency. Wait, why not just utilize SBRT, stereotactic body radiation therapy, for everyone in this category? We have fantastic data for ultra-hypofractionation. We can deliver the entire curative dose in just 5 fractions instead of 20 fractions. It is incredibly convenient, significantly cheaper. SBRT is the future. Why cling to moderate hypofractionation as a clean board default?
If we look at the radiobiology and the context of a high-stakes oral board exam, you have to be strategic. You are absolutely right that SBRT is a highly effective, evidence-based option for selected low and intermediate risk patients. The radiobiology actually supports it. Prostate cancer has an estimated alpha-beta ratio of roughly 1.5, which is exceptionally low. This means that the cancer cells are highly sensitive to large doses of radiation per fraction. Mathematically, larger fractions should kill the tumor more efficiently without proportionally increasing late toxicity.
So the math supports 5 fractions.
The math supports it, and trials like PASPO-D proved it can be done safely. However, moderate hypofractionation, 60 grays and 20 fractions, is universally accepted and heavily backed by massive Phase 3 trials, like the CH-MET trial in the UK and the PROPHET trial in Canada. If you enthusiastically offer SBRT for a complex, unfavorable intermediate case on the boards, the examiner might decide to test your depth.
They'll drag you down a rabbit hole.
Exactly. They might ask how you track the prostate during the 3 minutes the beam is on. They might quiz you on placing space-away-R hydrogels. And they will definitely demand you recite highly specific 5-fraction constraint tables that you might not know perfectly. 60 gray in 20 fractions is a solid, impenetrable fortress.
That is fantastic practical advice. Give the examiner the most robust, unimpeachable answer first. Now, stepping back into the treatment planning system, what is the major contouring pitfall for Case A? Where do junior residents consistently mess this up?
The single most common physical pitfall for the unfavorable intermediate intact case is unintentionally undercovering those proximal seminal vesicles. What practically happens is this. The resident meticulously draws the prostate. Then they draw a tiny, almost microscopic sliver of the seminal vesicles. They stop contouring because they assume that the physical radiation dose spilling outward from the highly conformal IMRT beams will simply naturally wash over and cover the rest of that required 1 centimeter proximal region.
They are relying on the penumbra, the physical edge of the radiation beam, to do the work for them.
Exactly. But with modern, highly conformal VMAT or static IMRT, the dose drop-off is not a gentle hill, it is a sheer cliff edge. The computer optimizer is relentlessly programmed to spare the adjacent bladder and bowel. If you do not explicitly draw a contour around that entire proximal 1 centimeter and tell the computer, I demand 60 gray exactly here, the optimizer will aggressively carve the high-dose region right away from that space.
And you'll drastically underdose a known, high-risk, microscopic target area.
You must contour exactly what you intend to treat. The computer cannot read your mind.
That stark reality perfectly transitions us to our next complex scenario. So we've mastered the intact gland in Case A. But what happens to our targets when the surgeon has already removed the prostate? Let's explore Case B, the salvage postoperative case.
The postoperative pelvis is arguably the single highest yield and most heavily tested contouring topic on the entire genitourinary oral board exam. It fundamentally tests your 3-dimensional anatomical understanding.
Here is the presentation for Case B. We have a 68-year-old man. 2 years ago, he underwent a robotic-assisted laparoscopic radical prostatectomy. His final surgical pathology report demonstrated PT3A disease, meaning the cancer had microscopically broken through the prostatic capsule into the surrounding periprostatic fat.
Right.
His final Gleason score was 4 + 3 = 7, and he had a focal positive posterolateral surgical margin. The surgeon also performed a pelvic lymph node dissection, sampling 8 nodes, all of which were benign. Following the surgery, his PSA nicely dropped to an undetectable level, but recently it began steadily rising. It is currently at 0.25 with a calculated PSA doubling time of approximately 9 months.
So the timeline in the labs confirm we are dealing with a classic biochemical recurrence. The cancer is back.
Yes, the clinical alarm bells are ringing. We immediately obtained a high-resolution PSMA PET scan, which reveals a small, subtle area of radiotracer uptake right at the right vesicurethral anastomosis. Crucially, there is no nodal disease and no distant bone metastases. Clinically evaluating the patient, he is fully continent, wearing 0 pads a day.
Which is a fantastic functional outcome we want to preserve.
Absolutely. The urologist has referred him back to us for early salvage radiation. So the complex question is twofold. First, are we treating the prostate surgical bed alone or the prostate bed plus the pelvic lymph nodes? And second, how do you physically draw a post-op bed when the organ is missing?
Let's tackle the physical contouring challenge first, because the post-prostatectomy CTV is a massive conceptual hurdle. When the urologist physically removes the prostate, the entire architecture of the lower pelvis collapses and shifts to fill the void. The bladder physically drops downward due to gravity to meet the membranous urethra. The anterior wall of the rectum pulls forward into that empty surgical space. You're left trying to irradiate a ghost.
The abstract anatomical space where the prostate used to live.
Exactly. The classic, most effective mental model for conceptualizing the post-op CTV on a sagittal CT slice is the toilet bowl analogy, or sometimes called the dumbbell shape.
The toilet bowl analogy is brilliant. It instantly makes the abstract shape concrete.
It really does. To draw it correctly, you have to think of the target volume in two distinct anatomical zones. The zone below the superior aspect of the pubic symphysis and the much larger zone above it. Below the pubic symphysis, the target volume is very narrow. This is the drain of the toilet bowl. This narrow region encompasses the vesicurethral anastomosis, or VUA, which is the physical surgical connection where the bladder neck was sutured to the urethra. This area is sandwiched tightly between the dense bone of the pubic symphysis anteriorly and the anterior rectal wall directly posteriorly. There is very little margin for error here.
And then what happens as we move superiorly above the symphysis?
As you scroll above the symphysis, the target volume significantly widens out, that is, the bowl of the toilet. Anteriorly, your contour must pull forward to encompass the posterior aspect of the bladder wall, because microscopic disease frequently tracks upward along the bladder neck muscles. Posteriorly, the contour must extend deeper into the retrovesical space and the mesorectal fascia region. And superiorly, your contour must widen to encompass the entire seminal vesical bed, guided by the surgical clips left by the urologist.
Let's focus on those surgical clips for a critical second. I have watched residents sit at the computer and blindly draw circles around every single metallic clip the surgeon left behind, completely ignoring the surrounding anatomy and eventually dragging their target volume way up into the sigmoid colon.
Yes, that is a classic beginner's trap. Do not blindly chase superiorly migrated clips into the bowel. Over the span of 2 years, as the pelvis heals and shifts, those clips can float far away from the actual original surgical bed. Anatomy always wins over artifacts. You do not radiate loops of bowel just because a clip migrated there.
Now, I want to drill down into finding the inferior border, because you mentioned the VUA, the anastomosis. How do you actually find that exact inferior border on a grayscale CT scan without the benefit of an MRI? Missing this is a fatal board error.
It is the ultimate contouring trap. The inferior border of your post-op clinical target volume must be placed approximately 8 to 12 millimeters below the vesicurethral anastomosis. In practical terms, you are looking for that tiny dark gray circle of fluid surrounded by the muscle, the last CT slice, where you can confidently identify urine inside the membranous urethra.
But practically speaking, sometimes the CT scan is just a blurry mess of soft tissue. You cannot clearly see the urine stripe.
Exactly. When the VUA is hiding from you, you need a robust, undeniable anatomical fallback. That structural fallback is the penile bulb. You scroll inferiorly until you find the bulbous, slightly brighter structure of the penile bulb, and you place your absolute inferior slice just above it. If you stop your contour higher up, you are effectively missing the cancer.
Which brings me to the next massive trap. This is where modern imaging creates a psychological dilemma. We have this beautiful, highly sensitive PSMA PET scan for case B, and it shows exactly where the disease is. It's glowing right at the VUA. Can I just draw a tight margin around that single glowing spot, zap it with SBRT, and spare the rest of the bladder and rectum?
The short answer is absolutely not. And if you propose that localized approach to a board examiner, you will instantly fail the question. This is what we call the PE trap.
Walk us through the biological reasoning. Why can't we just treat what we see?
Because a PSMA PET scan, as technologically amazing as it is, still has a fundamental physical limit of resolution. The radiotracer might clearly illuminate a dense 4-millimeter macroscopic nodule of tumor at the anastomosis, but it physically cannot show you the thousands of microscopic prostate cancer cells that are simultaneously scattered throughout the rest of the surgical bed. Right. The board-correct, evidence-based answer is always to contour and treat the entire standard post-prostatectomy bed.
So we are committed to treating the whole bed. But what about that bright glowing spot? We just ignore the PET scan.
No, you absolutely utilize the PET data, but you layer it. You treat the entire comprehensive prostate surgical bed to your standard salvage dose, which is generally in the range of 64.8 to 70.2 gray. And then you layer a simultaneous integrated boost specifically targeted onto that macroscopic PET-avid recurrence. You might take that specific small volume up to 72 or 74 gray. The macroscopic disease gets the high dose, but the foundation of the treatment must be irradiating the whole bed.
That layered approach makes perfect oncologic sense. Now let's address the second highly debated half of the consult question, the intensification debate. This patient has a rising PSA, PT3A, extracapsular disease, and a positive margin. Do we just treat the prostate bed, or do we bring in the whole pelvis, treating the pelvic lymph nodes, and add a course of ADT?
This is a scenario where you must demonstrate your maturity as an oncologist. Early salvage prostate bed radiation is the central, absolutely required recommendation. But the decision regarding intensification, adding pelvic nodes and short-course ADT, that requires a nuanced shared decision-making discussion.
We have to base that discussion on trials like SBP, correct?
Exactly. The SBT trial randomized post-operative salvage patients into 3 arms. Arm 1 received radiation to the prostate bed alone. Arm 2 received the bed, plus short-course ADT, and Arm 3 received the bed, the pelvic lymph nodes, and short-course ADT.
Okay.
The data clearly demonstrated that the most intensive approach, Arm 3, provided the highest rates of freedom from progression. For our specific vignette in Case B, I would strongly discuss intensification, but I would frame it to the examiner and to the patient as a shared decision-making point, not a rigid dictatorial mandate. You offer the intensified approach as a strongly supported option, but you acknowledge the toxicity trade-offs like bowel toxicity and hot flashes.
That nuance is what separates a technician from an oncologist. So we have comprehensively covered the intact workhorse, and we have navigated the abstract geometry of the salvage post-op. Now we move to Case C. And while treating the pelvic lymph nodes was a maybe in Case B, they are the main event in Case C.
Case C represents the highest stakes in the clinic. It is the high-risk intact patient.
Here's the presentation. We have a 68-year-old man. His staging MRI shows massive CT3A disease, meaning the tumor is visibly bulging through the prostatic capsule into the surrounding fat. His PSA is dangerously elevated at 24. His biopsy results are staggering. Lesion 4 plus 5 equals 9, which is grade group 5, with 10 out of 12 cores positive bilaterally.
That is extremely high-risk disease. The microscopic risk of spread is immense.
Now, interestingly, we obtained a staging PSMA PET scan. It brightly highlights the dominant intraprostatic lesion and confirms the extracapsular extension, but it is entirely negative for any PSMA-avid pelvic lymph nodes or distant bone metastases.
Which is obviously a relief for the patient, but we cannot be lured into a false sense of security by a clean scan.
Right. The consult question asks, despite the completely negative PET scan, do we still treat the whole pelvis? How do we physically draw those complex nodal basins? And how do we deliver a massive boost to the prostate?
Let's tackle the PET scan discrepancy first. Even with a negative high-resolution PSMA PET, his estimated clinical risk for harboring microscopic, invisible cancer cells within his lymph nodes is massive. If you run his numbers through predictive nomograms, his risk of nodal involvement far exceeds the standard 15% threshold where we mandate elective nodal irradiation. The microscopic disease is likely already there. So whole pelvis radiation is absolutely on the table.
Okay, we are committed to drawing the pelvic lymph nodes. Let's walk through nodal contouring mastery. Where exactly do we start the superior border of our field?
You must start superiorly. And when asked, you need to explicitly state to the examiner that you are referencing the updated pelvic nodal contouring atlas. The superior border of your nodal clinical target volume begins at the more superior of the aortic bifurcation or the inferior vena cava, the IVC bifurcation.
Yeah, I thought the classic teaching was to start the fields at the interspace between the L5 and S1 vertebrae.
No, absolutely not L5-S1. That is outdated legacy teaching from the era of 2D X-ray planning. Saying L5-S1 on the modern oral boards is a fantastic way to instantly signal to the examiner that you have not read the updated consensus guidelines. Lymphatic drainage fundamentally follows the major blood vessels. It must be the more superior of the two bifurcations.
Speaking of those high major vessels, I have a great AJCC staging pearl about the superior region. When we draw our standard whole pelvis fields up to the aortic bifurcation, we are inherently including the common iliac lymph nodes. But if a patient actually presents with a frankly positive, enlarged common iliac lymph node, how does the AJCC officially stage that cancer?
It is staged as M1A. It is officially classified as non-regional metastatic disease.
Exactly. It feels completely counterintuitive. We routinely include the common iliac nodes in our daily elective fields, but If there is actual visible disease there, the staging manual calls it a distant metastasis. The official regional nodes for prostate cancer stop at the true pelvis, the external iliacs, the internal iliacs, the obturator, and the sacral nodes. The common iliacs are technically non-regional.
It is a brilliant, multifaceted trap.
Yeah.
So returning to the contour, we start at the bifurcation, we cover the common iliacs, and then we trace the major vessels downward as they branch. You locate the external iliac vessels and follow them inferiorly until they pass just under the inguinal ligament.
What about the internal vessels and the deep obturator space?
For the internal iliacs, you cannot just draw a tight 3-millimeter ring around the blood vessel itself. Lymph nodes live in the fatty connective tissue surrounding the vessels. For the obturator space, the crucial rule is to strictly exclude the mesorectum. A very common error is letting the obturator contour drift way too far posteriorly, spilling into the mesorectal fat space behind the prostate.
And moving inferiorly. Where exactly does the obturator space safely end?
The obturator nodal region tapers and ends at approximately the horizontal level where the seminal vesicles physically join the base of the prostate.
Lastly, we cannot forget the presacral strip.
You must carry the presacrophantos all the way down to the bottom of the S3 vertebral body. Do not stop early at S2. Do not go all the way down to the coccyx. The bottom of S3 is the classic, heavily tested anatomical answer.
Okay, so we have accurately contoured our massive pelvic lymph node volumes. What is our comprehensive dose strategy for case C?
We treat the wide elective pelvic nodal chains to a standard conventional fractionated dose, typically ranging from 45 to 50.4 gray. Then, because this patient has incredibly aggressive Gleason 9 disease in the prostate itself, we have to deliver a definitive, massive dose escalation, a boost specifically targeting the prostate and the proximal seminal vesicles.
Let's talk about the mechanics of that boost. I want to bring up the Ascender ART trial to guide our approach.
Ascender ART, a truly landmark controversial trial.
It is. The trial took high-risk patients like ours and randomized them after whole pelvis radiation. Half received a standard external beam radiation boost to the prostate. The other half received a brachytherapy boost. And the data showed that the brachytherapy arm had significantly better biochemical progression-free survival. So shouldn't we just mandate a brachytherapy boost for this patient on the boards?
What's fascinating here is how you interpret the totality of the trial evidence. The Ascender trial absolutely supports the biological concept that a brachytherapy boost provides superior biochemical control. However, that superior control came with a massive, sobering caveat, a significant, alarming increase in severe genitourinary toxicity.
Right. The patients in the brachytherapy arm experienced high rates of severe urethral strictures requiring surgery.
Very tough. And crucially for your board answer, you must understand the exact technique used. The Ascender trial utilized an LDR, low-dose rate, brachytherapy boost.
Right.
It did not use HDR or high-dose rate brachytherapy. If the patient's anatomy doesn't support an implant, or if your center simply doesn't perform them, a dose-escalated external beam boost using modern IMRT is completely acceptable.
And what about the systemic therapy? We cannot treat high-risk disease with local radiation alone.
For high-risk Gleason 9 disease, we are looking at long-course ADT. Generally, the guidelines recommend a duration of 18 to 36 months of testosterone suppression.
So what does this massive accumulation of information mean for the patient's actual physical anatomy? We spent all this time drawing these beautiful target volumes, but now we hit the physics side of the clinic. The dosimetry team is looking at the organs at risk. Let's transition to what I call the golden rule of constraints and toxicity.
This is exactly where you win or lose the clinical case. You can draw a geometrically perfect target, but if you do not understand the physical constraints of the normal tissue, the plan is inherently unsafe and you will fail.
I'm looking at the constraint tables and it feels like a massive trap. If I prescribe 60 gray in 20 fractions, but I evaluate the rectal safety using a 5-fraction SBRT constraint table, I'm essentially using a motorcycle repair manual to fix a commercial jet engine, right?
That is the perfect analogy. The golden rule is unyielding. The specific normal tissue constraint table you quote to the examiner must exactly match the mathematical fractionation scheme you just prescribed.
Break the radiobiology of that down for the listeners. Why are the numbers so different?
Because prostate cancer cells repair themselves differently than healthy rectal tissue. That difference in repair capacity is mathematically quantified by the alpha-beta ratio. When you hit the rectum with massive 7 or 8 gray daily doses in SBRT, the math of how that healthy tissue survives and repairs completely changes compared to a standard 2 gray daily dose. If you mix and match constraint families, it shows the examiner that you just blindly memorized a list of random numbers.
Let's ground this with concrete examples. For standard conventional fractionation, what are the classic rectal volume anchors?
For conventional long-course treatments, a rectal V40 must be less than about 35%, and a rectal V70 must be strictly less than about 20%. And specifically for KC, our high-risk whole pelvis plan, the small bowel becomes the most critical structure.
Okay, but what happens when we shift gears to moderate hypofractionation, like our 60 gray and 20 fractions for case A?
Do not try to mathematically improvise or extrapolate from the conventional numbers in your head. You must use the actual protocol-specific table that your department follows, typically derived directly from the trials like CHAP or PROFIT.
This entire discussion ultimately boils down to functional trade-offs. For case A, the fundamental physical trade-off is ensuring robust target coverage of the prostate and proximal seminal vesicles versus the high dose hitting the anterior rectal wall.
Yes, the consequences are severe. For case B, the most critical functional trade-off is ensuring adequate dosimetric coverage of the vesicourethral anastomosis versus preserving the patient's urinary continence.
And for case C, the dominant trade-off shifts dramatically superiorly into the abdomen. It becomes a battle of comprehensive pelvic nodal coverage versus the dose to the loops of small bowel.
Planning is ultimately an exercise in toxicity prevention.
All right, we have covered an immense amount of ground today. Let's lock this knowledge in with a rapid-fire review. It is time for the board blitz. I'm going to throw 3 high-yield, quick-fire clinical scenarios at you.
I am ready. Fire away.
Question 1. You have a 70-year-old man presenting with extremely high-risk prostate cancer. You are actively planning his definitive radiation with whole pelvis nodal coverage. Your junior resident proudly calls you over to review their contour, but you immediately notice they stop the superior border of the nodal CTV abruptly at the L5-S1 interspace. What is the precise correction you give them, and why?
I would immediately instruct them to extend that contour significantly further superiorly. The updated consensus pelvic nodal atlas strictly mandates that the superior border must begin at the more superior of the aortic bifurcation or the IVC bifurcation, not L5-S1.
Flawless. Question 2. You are contouring a complex post-prostatectomy salvage plan. Where exactly should the absolute inferior border of your CTV end, and what is your undeniable anatomical fallback if the primary landmark is completely obscured by surgical artifact?
The inferior border must extend approximately 8 to 12 millimeters below the surgical vesicourethral anastomosis. If the VUA is impossible to clearly identify, the universally safe fallback is to place your absolute inferior slice just superior to the penile bulb.
Perfect logic. Question 3. A trainee is presenting a 5-fraction prostate SBRT plan to you for approval. They confidently tell you the plan is perfectly safe to treat because the rectal V70 is well under 20%. What is the fundamental dangerous problem with their dosimetric proposal?
The fundamental problem is a profound misunderstanding of radiobiology. They are incorrectly quoting the wrong constraint family. The V70 limits are constraints explicitly designed for conventional fractionation. Applying those to an SBRT plan is clinically incredibly dangerous. The constraint table must always mathematically match the specific fractionation scheme prescribed.
Excellent. As we bring this intensive planning workshop to a close, let's step back. We took highly complex, abstract biological concepts and we successfully translated them into actual, tangible physical geometry.
We covered 3 incredibly distinct fundamental scenarios. We analyzed the intact, unfavorable, intermediate risk patient.
We navigated the ghost anatomy of the early salvage post-prostatectomy patient, mastering the critical toilet bowl contour.
And finally, we managed the high-risk intact patient, where comprehensive pelvic nodes were firmly on the table, exploring the Ascender Art-Tree trial's toxicity trade-offs.
If you can confidently explain the sim setup, the target definitions, the prescribed dose, and the anatomical pitfalls for each of these 3 distinct cases, you are not just ready to pass the oral boards. You are genuinely ready to be a safe, highly effective attending in the clinic.
And that reflection circles us right back to our very first thought. The pelvis might initially appear as a murky, terrifying landscape of millimeter trade-offs, but when you apply the right biological framework, you can navigate those muddy waters with absolute curative precision.
I couldn't agree more. And it does make you wonder, as artificial intelligence begins to auto-contour these microscopic risk zones for us in seconds, will the manual art of drawing the toilet bowl eventually become a lost historical skill? Or will our deep anatomical expertise become more vital than ever? It is absolutely something to think about. Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.